Hello dear students, welcome to Studental. I am Dr. Ishani Bindra. I am a prosthodontist and your mentor for today. The topic we'll be covering today is provisional restorations in fixed partial denture and their importance. So basically, what are the other terms which can be used for provisional restorations? They may be called as interim prosthesis, provisional prosthesis, and the process of making any provisional restoration is known as temporization. Unfortunately, temporary often conveys us the message that the requirements are unimportant, but this is not so. Provisional restorations are a vital part in fixed partial dentures. According to Glossary of Prosthodontic Terms, a provisional restoration may be defined as a fixed or a removable prosthesis designed to enhance aesthetics, stabilization, and function for a limited period of time, after which it is to be replaced by a definitive prosthesis. So why do we need these provisional restorations? Basically, after we are doing a tooth preparation for a single crown or for a fixed partial denture on a vital teeth, we have to protect the underlying pulpal tissues. We have to protect the teeth, the prepared teeth abutments from dental caries. The provisional restoration should provide proper comfort and function to the patient. It should prevent migration of the abutments. For example, when we are preparing any tooth for fixed partial dentures, originally the teeth which were unprepared were in tight contact with the adjacent teeth. But once we are done with the preparation, a proximal space is created between the prepared tooth and the adjacent unprepared tooth. So provisional restorations are given to prevent migration of abutments and to improve aesthetics. In this patient, we do not want a patient to go home like this. The other people, when they see the patient smiling, they'll get scared, and even the patient himself or herself will not be comfortable to smile. So in such cases, the provisional restorations will not only improve the aesthetics but also the confidence of the patient. So what are the ideal requirements of provisional restorations? According to Rosenstein, they may be classified under three categories, that is biological requirements, mechanical requirements, and aesthetic requirements. All these requirements in detail we'll be covering. Pay a little attention because this might be asked as a short answer question. Coming on to the first biological requirement, that is pulp protection. So whenever we are doing any tooth preparation on a vital tooth, there are two zones in which the patient will have maximum sensitivity. The first zone is when we are nearing the dentino enamel junction, and the second zone where the patient might have maximum sensitivity is when we are near the dentino pulpal junction. So in such cases, the provisional restoration should protect the tooth from the oral environment, thereby preventing sensitivity and irritation to the underlying tooth. The next biological requirement is maintaining good periodontal health. For example, in this patient, the margin of the provisional restoration is overextended and it is impinging on the marginal gingiva. Hence, we can see the gingiva is reacting to this overextension by showing signs of inflammation. If the prosthesis is, if this crown, temporary crown, is placed in the patient's mouth for a longer period of time, the gingiva will react by showing signs of gingival recession and bone loss. So any provisional restoration should have good marginal fit, proper contour and smooth surface so that there is no accumulation of plaque on the surface of provisional restoration, as well as they should facilitate easy plaque removal and thus maintain the periodontal health. Coming on to the next biological requirement, that is occlusal compatibility. So once we are done with tooth preparation, for example in this case if we are doing a tooth preparation for a single crown, so we are reducing the tooth, may it be 1.5 mm or may it be 2 mm in occlusally. So there will be a space which will be created between the opposing arches, that is between the maxillary and mandibular arch. A space will be created. So this space is usually filled by the provisional restoration. These restorations should have good occlusal compatibility. They should help to provide a comfortable and stable functional relationship by maintaining the interarch, that is between the maxillary and mandibular arch, and intra-arch stability, that is within the same arch, thereby preventing tooth migration or supraeruption. Prevention of fracture. Any provisional restoration should protect the underlying tooth surface from fracture. Mechanical requirements. The first one is resist functional load. So the provisional restoration which we are giving should have good compressive and flexural strength. But why? Because the strength of the material which we are using in fabrication of the provisional restoration is much lower than that of the definitive restoration material. For example, one of the most commonly used material for fabrication of provisional restoration is polymethyl methacrylate. So the strength of this polymethyl methacrylate is 1/20th the strength of the metal ceramic alloys which might be used for fabrication of definitive prostheses. Hence, and also the greatest stresses will occur whenever the patient will be chewing. So the greatest stresses on a provisional restoration occur during chewing. For in this case, if we are giving a provisional restoration for a fixed partial denture, so the area prone to fracture is the connector area, that is this area. So in such cases, the design of the provisional restoration has to be modified a little. The connector area in these provisional restorations is over contoured so that it doesn't fracture during mastication. The next mechanical requirement is these restorations should resist removal forces. Obviously, we don't want that we are giving the patient a provisional restoration and cementing it again with the help of a provisional cement, and after half an hour or 1 hour or maybe next day the patient returns and says that I have a dislodged prosthesis. So these restorations should have close adaptation to the prepared tooth surface to prevent displacement and re-cementation, which will increase patient visits. But at the same time, we want, since these are provisional restorations, temporary restorations, which are given till the permanent arrangement will arrive, so they should be easy to remove. So provisional restoration in many cases, for example, full mouth rehabilitation cases where we are giving full mouth crowns to the patient, the provisional restorations need to be removed time and then again re-cemented. So in such cases, they should be fabricated with adequate thickness and cemented with a weak cement so that they can be removed without breakage. Coming on to the aesthetic requirements, those restorations, provisional restorations which replace the anterior teeth need to be very aesthetic. They should have good color compatibility and translucency so that they mimic the original natural tooth. They should match the size, shape, color and texture of the restored tooth, especially in the anterior region. Color stability, very important factor. We don't want a provisional restoration to be discolored very early. If we are giving the provisional restoration for a longer period of time, for example in full mouth rehabilitation cases, and the patient has a habit of maybe smoking or drinking tea, coffee, or having something with turmeric in it, for example turmeric milk, the provisional restoration might absorb the stains from all these food materials and it might get stained. So we don't want this to happen. So the color stability of the provisional restoration is also an important factor. In this case, because the provisional restoration was improperly contoured, there is not enough embrasure space here which is present, and the provisional restorations here are impinging on the dental papilla. This shows signs of gingival inflammation. So whenever the patient will smile also, this areas of over contouring and reddish discoloration of the gingiva will be seen, which will be unesthetic. So proper contouring of the provisional restoration, thus mimicking the original natural tooth, is very important for aesthetics. Now, how do we classify the provisional restorations? They can be classified according to the method of fabrication, that is preformed, which are commercially available, which are preformed, or custom made. Custom made means made especially for a particular patient. According to the material used, they can be classified. The material can be resin based material. Again, it may be classified into preformed or custom made. or metals, again preformed or custom made. According to the duration of use, they may be classified as those used for short term and those used for long term. According to the technique of fabrication, these restorations may be classified as those fabricated by direct technique, by indirect technique, and the third is by direct indirect technique. So this is a simplified version of the classification. The provisional restorations can be either custom made or prefabricated, again depending upon the material. It may be resin based or metal based, according to the technique of fabrication, direct, indirect, and direct indirect technique, and according to the material used. So classification is also important from exam point of view. This is a simplified table for classification. All these methods of fabrication and the materials used for provisional restorations we'll be covering in the further lecture. So what are the ideal requirements of these materials which we use for provisional restorations? They should have good strength and wear resistance, should be biocompatible, should have good dimensional stability, they should be easy to contour and polish, they should be non-irritating to the underlying tooth and the adjacent soft tissues, and should be chemically compatible with the luting cement which we are using. They should be aesthetically acceptable, should have good working and setting time, and easy to repair. Because sometimes when we remove the provisional restorations, there might be areas where the provisional restoration gets chipped off. So they should be easy to repair. Instead of fabrication of a whole new provisional restoration, if they are easy to repair, um, we can just repair the provisional restoration in the area it has got fractured or broken. Sorry. So according to the material used, the provisional restorations may be resin based, that is acrylics, or bisacrylic composites. So what are the advantages of acrylics? Acrylics is one of the most widely used material for fabrication of provisional restorations. The advantages of these are have a low cost, good wear resistance, good aesthetics, and good color stability. But the disadvantages include significant amount of heat which is given by the exothermic reaction when these materials set, high degree of polymerization shrinkage, strong odor, short working time, and difficult to repair. And also they are radiolucent. In case the patient digests the material, we cannot detect where it has gone. Bisacrylic composites, one of again nowadays it is one of the most widely used material for fabrication of provisionals. The advantages as compared to the conventional acrylics are less shrinkage, excellent aesthetics, um, good. Most products use automix delivery. The disadvantages are greater cost, so that is a very big disadvantage. If the patient is not of paying capacity, we cannot use high-end materials. More brittle as compared to acrylics. Other materials which may be used are metal-based, aluminium, nickel, chrome, and tin silver. So coming on to the first resin-based preformed material, they are the polycarbonate crowns. What does polycarbonate means? A combination of microglass fibers with polycarbonate plastic material. Here we can see these are polycarbonate. This is a polycarbonate crown. They possess high impact strength, abrasion resistance, and good bond with the PMMA. So it has the most uh, important advantage of polycarbonate crown is that it has best aesthetics among all preformed crowns. It is available in the shape of incisor, canine, and premolars, and available in different sizes. So how do we select which crown to be used for which patient? In this case, once we are done with the anterior tooth preparation, first the mold it is selected. After the mold selection it is done, the size selection of the polycarbonate crown is done. Since these are pre-formed crowns, the fitting might not be very good. So the fitting is improved with relining this polycarbonate crown with the help of acrylic resin. As I told you earlier, these crowns they bond with the acrylic resin. And this is the finished temporary in place. So this is very aesthetic, mimics the adjacent natural tooth, This is the process how which we can cement a polycarbonate crown. The next material, which is again resin based, is cellulose acetate. It is thin, soft, transparent, as we can see in this image, scaffold material, again available in different shapes and sizes, but it does not bond to the relining resin. So what do we do? After tooth preparation, again mold selection and size selection. Then we have to see the fit of the cellulose acetate material, we form crown, and after this we fill acrylic resin in this crown, and once the acrylic resin sets, the cellulose acetate material it is removed, and the crown which we get is inserted and lubricated and cemented over the prepared tooth. Coming on to the next material, these are metal based. Aluminium, generally limited to posterior for aesthetics. Obviously we cannot give this metal crown in the anterior region. It is available as a simple shell. Again, it provides good adaptation and may be relined with resin to obtain a better fit and rigidity before luting it onto the prepared tooth. The next metal is nickel chrome. Basically, nickel chrome alloys are used as crowns in children with damaged primary teeth. They are trimmed, contoured, and adapted to the tooth. Strong cements in such cases should be used for luting. So these were all the prefabricated crowns which are available in different sizes, shapes, materials. Now coming on to the custom techniques. Custom means customized for a particular patient. So according to that, they are classified into direct technique, indirect, and direct indirect technique. What is a direct technique? So if we have to prepare, for example, these anterior teeth, so before preparation, we will make an impression, maybe a putty index impression with for the patient. After tooth preparation, this putty impression is relined with any temporary material of your choice, and the impression tray is inserted into the patient's mouth. The material is allowed to set properly. It is removed, trimmed, finished, polished, contoured, and then luted with the help of provisional cement. So why is it called a direct technique? Why do we call it a direct technique? Because directly we are preparing the temporary restoration or the provisional restoration in the patient's mouth. We are not taking any laboratory help, or we are not doing any step which is not chair side. All these procedures are done chair side when the patient is present on the dental chair, and directly in the all the steps are done directly in the oral cavity. Hence the name direct technique. So what is indirect technique? Now we can understand any procedure or technique which is done in the absence of the patient in the laboratory is the indirect technique. It is probably the best overall technique for FPDs and provides the most predictable result with least risk to the patient. So what is the procedure? After shade selection and tooth preparation, an alginate impression is made. After making the impression, what we'll do, we'll pour the impression in quick setting plaster and or stone and allow the material to set. Once the material has set, we obtain the cast, trim it. The ESF, that is the external surface form, is usually made from diagnostic waxing of the proposed restoration. So whatever tooth we have prepared, a diagnostic waxing is done over this prepared tooth, and after that diagnostic waxing, a putty index of this waxing it is made. On the cast, separating medium is painted. Whatever the putty index of the diagnostic waxing we have made is filled with the provisional restorative material, for example acrylic of our choice, and again after the material is filled into the proper space, it is seated onto the tissue surface of the cast and secured with the help of rubber bands. After the material sets and polymerizes completely, we obtain the provisional restoration, which is again finished, polished, contoured, and checked into the patient's mouth, and then luted with the help of provisional cement. So this was all about the indirect technique. Why do we call it indirect technique? Because all these steps are done when the patient, not in the patient's mouth, they are done when the patient is away, that is in the dental laboratory. Hence it is known as indirect technique. Now they're coming on to the third technique, which uses a combination of both the direct and the indirect technique, hence the name direct indirect technique. So when the patient has multiple missing teeth, or maybe we need to give many crowns and bridges to the patient, first after the impressions are obtained on the diagnostic cast, diagnostic wax up of whatever procedure we are doing is done. After the diagnostic wax up, a putty index of this cast is made, and after we obtain the putty index, the abutment teeth, a tooth preparation, it is done on the cast. See here we can see after the tooth preparation we get the cast, and on this cast separating medium it is painted again. So the putty index which we obtained here at this step is filled again with any provisional restorative material, for example acrylic resin, and this putty index with the material is again secured onto the cast with the help of rubber bands. After the material polymerizes, this is the provisional restoration which we will get. So these were all the steps which are done in the dental laboratory. Now what do we do in the patient's mouth? First we'll prepare the teeth. After teeth preparation, we'll remove these provisional restorations from the cast and try to seat it in the patient's mouth. Obviously, the preparation which we are doing on the cast and the preparation which we are doing in the patient's mouth will have some degree of there will be some change in the preparation. So these provisional restorations are again relined with the same material with acrylic resin, and then placed intraorally into the patient's mouth. So this will improve the overall fit of the provisional restoration. After the material sets, again the restoration is removed, finished, polished, and this is what we get as the final provisional restoration. So why do we call it as direct indirect technique? Because some steps are done directly in the patient's mouth, whereas other steps are done when the patient is absent in the laboratory. Hence a combination of these two techniques, it is known as direct indirect technique. How do we cement the provisional restorations? We do not want to cement the provisional restorations with a permanent cement. So ideal properties of the cement which we are using are ability to seal against leakage of oral fluid. It should have good strength, but the strength should be such that when we have intentional removal of the provisional restoration, it should easily facilitate the removal. It should have low solubility in the oral environment, good chemical compatibility with the provisional polymer, ease of eliminating excess, and adequate working time but short setting time. So what cements we might use? Zinc oxide eugenol, non-eugenol cements, reinforced zinc oxide eugenol cement, zinc phosphate, zinc polycarboxylate, glass ionomer cement. These cements are not used because of comparatively high strength, and thus this makes intentional removal difficult. Also, glass ionomer cement, if we use as a provisional cement, it will adhere to the tooth and will change the tooth preparation which we have done. So usually non-eugenol zinc oxide cements are preferred. Coming on to the summary, although provisional restorations are usually intended for short term and then discarded, they can be made to provide pleasing aesthetics, adequate support, good protection for the teeth while maintaining periodontal health. They may be fabricated in the dental office or in the dental laboratory from any of the several commercially available materials and by a number of practical methods. The success of fixed prosthodontic often depends on the care with which the provisional restoration is designed and fabricated. So, thank you.